Hello and welcome to this Pharmacy Times Practice Pearl webinar, the best practices for the management of acute myeloid leukemia. I'm Dr. Katie Koulis, a hematology oncology clinical pharmacist at Vanderbilt University Medical Center in Nashville, Tennessee. Joining me today in this discussion are Dr. Amanda Brahim, also a hematology oncology clinical pharmacist, however, at Memorial Cancer Institute in Pembroke Pines, Florida, as well as Dr. Yehuda Deutsch, who is a physician practicing in the Department of Malignant Hematology and Cellular Therapy, also at Memorial Cancer Institute in Pembroke Pines, Florida. So as I mentioned, we are going to discuss the best practices in the management of AML, including patient identification, formulary decisions, as well as providing therapy from an outpatient setting for optimal care. So let's kick things off. Yehuda, if you could help us get the discussion started with a brief overview of AML, maybe starting kind of with the basics of the pathophysiology.
Of course, thank you so much. So AML, acute myeloid leukemia, is the most common form of acute leukemia in adults. There's about 20,000 new cases of AML each year in the United States, and this incidence has been increasing over the years. So AML, I think it's first important to know, of course, the function of the bone marrow. The bone marrow is an organ with the function to produce hematopoietic or blood cells, white blood cells, red blood cells, and platelets. And AML occurs when there's a transformation, a malignant transformation of the myeloid precursor cells. These are cells that develop into the mature, normal white cells, red cells, platelets. And what happens is you get a clone of these abnormal cells, and they can grow, they can proliferate, and they also have an inability to differentiate into normal, mature blood cells. And this causes the bone marrow to malfunction. The function of the blood cells are the function of the bone marrow decreases, and the amount of normal cells declines. And this can occur for many reasons. There's a number of risk factors that can predispose to AML. We find that there are sometimes recurrent genetic or chromosomal abnormalities within these myeloid malignant cells. We also find genetic mutations in some of the really important cellular pathways of proliferation and differentiation, epigenetic regulators. And so AML can occur, and there's different forms of AML. There's some forms that we call de novo AML, and there's others that we call secondary. Secondary AML being AML leukemia that develops either from a pre-existing bone marrow disorder, and sometimes we call that AML with myelodysplasia related changes. And there's also secondary AML that can occur because of exposure to prior chemotherapy or radiation, and that's called therapy related AML. And these secondary AMLs are usually more aggressive and more resistant to treatments and more difficult to treat.
Amanda, can you give us an idea of what are some of the common signs and symptoms for patients with AML?
Yeah, so as Yehuda mentioned, it is characterized by a bone marrow failure. So we'll see patients coming with a range of signs and symptoms that have to do with other blood cells that normally are produced in the bone marrow and not having enough of those. So patients will come in with days, weeks, sometimes months of fatigue. We can see primary signs such as bleeding. Sometimes we'll see high white blood cell count, sometimes low white blood cell count. And all of the signs and symptoms that patients present with, again, is because of that primary bone marrow failure that occurs because of the AML myeloid cells crowding out the rest of the good cells from the bone marrow.
Great, thank you. I know that at my institution, typically the first time we'll see our AML patients is when they either get transferred to our institution from an outside hospital as we're a referral center, or they'll show up referred to us by their primary care provider to look a little closer in some things that are abnormal. Yehuda, can you walk us through all the different testing and laboratory information that we need to collect to have a diagnosis of AML?
Of course. So as both of you have mentioned, one of the most important and most common finding is an abnormality in blood cells. So we really first start off with a complete blood count. We often see in the CBC low hemoglobin, anemia, low platelets, and the white blood cell count can either be high or low. And it's the differential and looking at the blood smear to determine what type of white blood cells are there. Another test that we often do from the peripheral blood would be a flow cytometry test. And this test is able to identify the type of cells and the abnormal cells and try to identify the population of myeloblasts of the leukemia cell. And really the way to confirm the diagnosis of AML would be with a bone marrow biopsy and aspiration. This can be done either inpatient or outpatient. And with the help of the hematopathologist, they can confirm the diagnosis of AML. And as we mentioned before, there are different forms or subtypes of AML, and the distinctions between those forms is really made with the genetic and molecular analyses. And so from the bone marrow biopsy or even the peripheral blood, we can check chromosome abnormalities with a karyotype. We also use FISH testing as well as molecular testing either via PCR or next generation sequencing. And we do this some of these can be done as a standalone test or a panel. And the panel that we definitely need to test for are those mutations that can alter the prognosis, that can be predictive, and also can be targeted. Some of these include mutations in FLT3, both the ITD and TKD, NPM1, other mutations such as TP53, IDH1 and IDH2 mutations, and mutations in the RAS family. There are other types of tests that can be done. We know that for most other types of cancers, especially other hematologic cancers like lymphoma, you always need to do imaging tests, CT scans or PET scans. That's not really the case with acute myeloid leukemia. Most patients do not have tumors or lymphadenopathy. And if they do, then that would be called extramedullary disease. And so sometimes we do need imaging for the diagnostic workup.
Can you give us an idea from, say, the time that you have a patient present for a suspected AML to how long it will take you to collect all this information? And then what information is necessary for you to have before you can make your treatment decision?
So that's a really important question. So patients that usually present with acute leukemia, they often can be very sick and sometimes needing treatment immediately. But there are also a population of patients who present incidentally with no symptoms. And these patients probably have a little bit more time for the diagnostic workup. It does depend on if the patient presents in the hospital or in the outpatient setting, but we typically try to get the peripheral blood tests and the bone marrow biopsy done within 1 or 2 days. And once that test is done, some results take a little bit longer to come back. It used to be that people would want to start induction therapy immediately within 24 or 48 hours from the diagnosis. However, we know that there are significant differences in the way we treat AML nowadays. And so we do need to figure out a little bit more information about the leukemia before we actually decide what treatment is appropriate. And so nowadays it is normal to wait a couple of days before starting therapy. And there's even some situations, even in some older patients, when we're trying to wait for these genetic tests, evaluation for clinical trials, where sometimes we can even wait about a week before starting therapy.
Gotcha. And is it also a common practice for you, say, when you have different patients presenting, particularly older patients, that you do have some suspicion that they may have an AML of MRC, that you would potentially send slightly different testing for them to look for specific MRC markers?
So we often run the same tests for all patients with AML, regardless of their age. But yes, when we do have a suspicion that a patient may have a secondary AML or AML with myelodysplasia related changes, we do need to try and get the chromosome analysis or the FISH testing done more quickly. It's usually the fish testing that can be resulted in about 48 hours. And so we do rely on that to try and make the diagnosis or confirm the diagnosis of the type of AML, and the molecular testing as well. Some of the testing can be resulted also in about 48 hours, while some others take a little bit longer.
Great. So Amanda, once we get all of these tests, and obviously we would like to have all the information now, and it's becoming to be more and more information that we are able to get for each patient as we learn more about the biology of AML. Walk us through the pharmacist perspective when we do start learning the molecular and genetic kind of abnormalities of each patient's AML and how that affects your recommendations for their optimal treatment pathway.
Yeah, absolutely. So up until 2-3 years ago, I think the answer was pretty simple. If they're fit, they get 7+3 induction. If they're not fit, they get something else to just kind of hold them over. So to an extent, that's still a decision or a deciding point that we look at early on to see whether or not the patient is a candidate for intensive induction chemotherapy. So that's kind of that first discussion that we have. So we look at the patient age, but not just the age, but overall fitness is what we take into account. And from there, we make a decision whether or not this patient is a candidate for intensive induction chemotherapy. We also like to think ahead of time whether or not this patient would benefit from a transplant. So that's a conversation that we have early on to determine our therapy. From there, depending on how much information we have, and like Yehuda mentioned, we tend to get that back within a few days to a week. We tend to see the karyotype, molecular abnormalities, so then we can make a better decision. So if the patient has a FLT3 mutation, we'll always add on a midostaurin if we do 7 and 3 intensive chemotherapy induction. And our institution uses high-dose daunorubicin with our 7 and 3, but with our midostaurin, we leave it at 60. And then if the patient may not be a candidate for intensive induction chemotherapy, but they have specific mutations that we can target, such as IDH1 or IDH2, we'll try and use targeted therapy as well.
Great. And Yehuda, outside of all of these laboratory and diagnostic markers, what are some other patient-specific factors that you take into account when you're deciding on the optimal regimen in AML?
Right. So as Amanda was describing, there are many disease-specific factors that we take into account when deciding on treatment, but just as important is the patient-specific abnormalities. So patient-specific factors, excuse me. So it's not just the age of the patient, it's really the fitness of the patient. So once patients are around 60 and older, that's when we really need to focus in on their fitness, and we look at their comorbidities. Patients with more comorbidities obviously have higher risk of complications. We not only is it like disease or medical issues, but we also look at patients' family and social support because going through intensive therapy for AML in that matter, you really do need a good support system. You need to have access to be able to get to a medical hospital office facility for very frequent visits, so you need to have transportation. And when you're at home, you can be having a lot of symptoms or side effects, and you definitely need to have that support at home. And so we look at not just the patient, but their family and social support as well.
Great, thank you. So switching gears a little bit, Amanda, I wanted to just touch on, can you give us a little idea of what is who is on your P&T committee at your institution?
Yeah, so our institution has a system-wide specific hematology oncology P&T. It's comprised of a multidisciplinary team. So we have physicians, we have pharmacists, we have advanced practice providers such as APRNs and PAs, as well as nurses. So generally, when we consider drugs for formulary status, we have a physician and pharmacist dyad conducting literature review and analysis. They'll prepare that and present that to the P&T with their recommendation for addition to formulary. And then we vote on it and it goes to a system PNT committee for final approval.
And currently, what treatments are on your formulary for management of AML?
So we do have, generally we do have a distinct inpatient and outpatient formulary, just to make sure that we're both therapeutically and pharmacoeconomically optimizing our treatments for patients. So on our formulary, on the inpatient side, we have our standard, kind of our classic chemotherapy such as 7 and 3. We also have CPX-351, the liposomal form of daunorubicin and cytarabine, which was approved about 2 years ago. And then hypomethylating agents. In terms of targeted therapy, what we have on the inpatient formulary is midostaurin, the FLT3 targeted agent. And we also added venetoclax recently on the inpatient formulary specifically because we recognize that in certain cases, we do want to be able to start venetoclax therapy on the inpatient side.
For some of the other oral agents, do you have a different formulary for outpatient?
So our outpatient formulary is a bit more liberal. As if there's evidence and it follows a good logic in terms of and fits into our AML treatment pathway overall, those agents are approved. And then, you know, we try to work with insurance companies. We do have a specialty pharmacy within our health system, which is really nice because we're able to keep things in-house and we have a little bit more control over things like prior authorization processes. So we have a tighter monitoring process going on with pharmacists, physicians, and patients all working together to get optimal therapy.
Great. Yehuda, as the treating physician, what are some of the specific safety concerns that you take into mind when choosing certain regimens for AML patients?
So first and foremost, a risk of infections and cytopenias, but that's truly inherent in the disease itself. And so all patients with AML will have low blood counts, need for transfusions, and risk of infections. So when we're dealing with treatment, treatment can make the cytopenias worse. Treatment can impact other parts of the immune system, increasing the risk for infections, and those infections could be life-threatening. The types of infections that we see the most really are bacterial infections, but they could be fungal and other opportunistic and viral infections as well. And so for our trying to monitor for these types of infections and also to try and prevent them using prophylaxis, using antiviral prophylaxis, antibacterial, as well as antifungal prophylaxis for those patients that are severely neutropenic, and even using antifungals with mold coverage. There are many other types of toxicities and safety concerns depending on what type of treatment we use. One of the other common safety concerns with acute myeloid leukemia could be tumor lysis syndrome, and that tumor lysis syndrome also can occur not even with treatment, but just from the disease itself. And so we also always have to be mindful and watch for tumor lysis syndrome, monitoring blood tests, and also to prevent it, making sure patients have adequate hydration and using allopurinol or other medications such as respiricase if they develop tumor lysis syndrome. And we have to know what their risk of developing tumor lysis syndrome is, and if they're going to be treated as outpatient, we have to make sure that we're monitoring for that really closely. Some of the other types of toxicities that could occur, especially with some of the newer drugs, is one thing called differentiation syndrome. Most of us know about differentiation syndrome. Most classically, it's APL, promyelocytic leukemia. And we know that because the main problem in APL is a block in differentiation. And once you start treatment, the cells can start to differentiate and develop this differentiation syndrome, which is usually characterized by increasing white blood cell count, fevers, accumulation of fluid, pulmonary edema, shortness of breath. And this can be very serious. And we typically did not see this in other forms of AML until recently. with some of the oral targeted therapies, especially the IDH inhibitors. But even with the FLT3 inhibitors, we can see differentiation syndrome, and we have to be really mindful and watch out for this complication.
I think Yehuda is touching on an excellent point where we also have to make sure that we're really educating patients and their caregivers to look out for things like differentiation syndrome, because they're not hospitalized when we start them on IDH 1 and 2 inhibitors. And these delayed differentiation syndromes often can be mistaken for something else. So it is really important to have adequate education both upfront and then ongoing.
Great, thank you. And so with the boom, Amanda, of options to treat AML patients, you've obviously been really busy with your P&T committee, having different ones on formulary, managing inpatient versus outpatient. Tell us, do you have a formal medication utilization evaluation that you're doing for these new therapies to ensure that you're doing the optimal options?
Yes, absolutely. As you mentioned, it's been booming the last couple of years, which is a good problem to have, but we want to make sure that whenever we're treating patients, that we're following a pathway and that we're doing the right thing. I think if you have solid phase 3 randomized clinical data around, decisions are a little bit easier to be made, but with some of the new targeted agents, the trials that they're getting approved on are quite small. They may or may not adequately represent our specific population. So there's still a lot of questions to be answered. So to answer your question, yes, we do set out with specific drugs to have medication use evaluations. For an example, gemtuzumab ozogamicin, when it came back to market, that was one that right from the get-go, as we approved it in PNT, we set out to have a medication use evaluation about 6 months of use in, to recognize whether or not our population was responding as expected, and to see whether our safety profile was showing anything new as compared to the studies on which it got reapproved. So that's one example of a prospective MUE that we set out right at the approval stage for our PNT.
So, saying that we've had all of these drugs come to market, obviously you can't be doing a constant MUE of all of them. Are there different therapies? So you mentioned gemtuzumab, obviously that was on kind of everyone's radar since it had been removed from the market previously. So are there different drugs that you maybe prioritized MUEs for as you approve versus doing them on all the time?
Yeah, absolutely. I think gemtuzumab was a good example just because there was a real safety concern. So that was one that was our priority. So number one would be anything that we would have a safety concern over, or that we're not sure how much clinical benefit a patient could get, but there is a sense of real harm that we could see if we're not using it prudently. That would definitely be on our highest priority list. And from then on, it's kind of more, are we using things appropriately and are the outcomes as expected?
Okay, great. I think both Amanda and Yehuda have definitely touched on the factor that, we typically thought or were taught, when you treat AML, it's an inpatient therapy, you get 7+3, or you get a palliative route. And with the approval of new novel formulations or targeted agents, we have a lot more to think about when we get a newly diagnosed AML patient to treat. So Amanda, can you kind of touch base on what you said? You mentioned some of the agents that are on your formulary, but talk about the administration site, which ones you can give inpatient versus outpatient, as well as touching a little bit on the different formulations of AML treatment options currently at your institution.
Yeah, I almost feel bad for the pharmacy students nowadays because we had it easy. It was just 7 and 3, and now they have a lot more to learn. And so that has been our challenge too. So like you mentioned, we typically think of hospitalization for intensive chemotherapy but drugs like CPX-351, which are an intensive chemotherapy, and it's basically just a liposomal form of 7+3, can actually be given in an outpatient setting, even though it is an IV formulation. Because it's not a continuous infusion, the right patient could be able to have their induction and consolidation treatment on an outpatient basis. So that's something that really was, I think, is new for all of us, that you can have a very intensive induction chemotherapy regimen for AML and still be able to send the patient home at the end of the day. And that's something that's actually really nice that we've been able to pilot and show good safety and efficacy outcomes.
And can you speak briefly on the different formulations for the different treatment options? Which ones are available orally or IV or sub-Q?
Yeah, absolutely. So 7 and 3 and CPX-351 are both IV formulations. Some of the targeted agents such as midostaurin, as well as the IDH1 and IDH2 inhibitors, enasidenib and ivosidenib, all three of them are oral agents. Venetoclax is also an oral agent that recently came to market.
And of course, going back to the hypomethylating agents, which are really agents. So some of those are intravenous, like azacitidine can be intravenous or subcutaneous, and decitabine being intravenous only. And soon, hopefully, there'll also be other types of hypomethylating agents that are oral as well.
Great. So Amanda spoke briefly about with the approval of CPX-351, I think that definitely provided a big change in AML for us to be able to offer a 7+3 like regimen in the outpatient setting. So CPX-351 being the liposomal formulation of daunorubicin and cytarabine, only given on days 1, 3, and 5 as a 90-minute infusion. So Yehuda, when that information came out, I know in the clinical trials, a small percentage did receive it as an outpatient. Talk about how your group heard about that information, then decided how you were going to treat people with either 7+3 or if they were the right candidate for CPX-351.
So as both of you were describing, historically AML therapy was all inpatient intensive therapy. But as time went on, we saw that many types of therapies, even hematopoietic stem cell transplantation, there are some centers that do them as outpatient. So we've always been trying to figure out what can be done as outpatient to help improve lots of factors, patients, the quality of life of the patients, and of course also utilization of all of medical resources. And so when CPX-351 was developed and being used and studied, we saw that despite prolonged cytopenias, sometimes even longer than just a standard 7+3 induction, and despite the prolonged cytopenias, it seemed to be tolerated a little bit better, especially by older patients. And so we saw that it was administered as an outpatient. It can be administered as an outpatient because it's not a continuous infusion like the cytarabine is in the standard 7+3. So patients started off getting it as an outpatient, but then they would have this planned admission to monitor for toxicities. But because we saw they tolerated a little bit better, we thought that maybe we would be able to keep the patients in the outpatient setting while monitoring them very closely. And so we also tried to do this with other regimens as well. And we saw that patients can do it. Of course, there's a lot of factors that we look into to try and figure out if they are the right candidates for that type of administration.
So obviously, this led to a kind of a change of scenery for some of your patients being able to be treated in an outpatient setting, which is great. I know at our institution, we do a lot of our stem cell transplants as an outpatient, which is kind of provides you with a totally different environment to a place where you're typically going to be inpatient for the duration of your transplant. So I know that you guys probably had to have some changes in your infrastructure to be able to monitor patients closely in the outpatient setting. Can you describe for us kind of what that clinic is like?
So for sure, that type of clinic, to be able to provide that type of care for the patients in the outpatient setting, it takes a lot of effort. Effort from the physicians, physicians, APP, pharmacists especially, and nursing, especially good nursing care as well. And so we developed this setting called IPOP. IPOP stands for inpatient, outpatient. It's got a little bit of both, and it's outpatient because patients come in as an outpatient and they go home at the end of the day. But it's got some inpatient parts because it is located right next to our inpatient unit. We do have nursing care that's almost similar to inpatient, where the patients are getting really continuous care throughout the time they're there. And the pharmacy support as well. It's, again, almost like an inpatient setting where there's a dedicated clinical pharmacist helping out with these, managing these patients. And patients will typically be scheduled in this setting to get some of these treatments, but then more importantly, when the treatment is completed and they're being monitored for these potential complications, cytopenias, infections, and everything that we've spoken about, patients often come to this IPOP clinic either daily or every other day. And there the nurses are giving, whether it's chemotherapy treatments, monitoring frequent labs, lots of transfusion support. And we also have to make sure that we have a good communication and a good process for admission for these patients into the actual inpatient team, because majority of the patients, actually really 100% of the patients that we've treated with CPX 351, even in an outpatient setting, they'll all eventually develop some sort of toxicity complication, especially febrile neutropenia, that will require an admission. So we have to have this process set up beforehand so that patients can, if they develop febrile neutropenia, they can get their workup, get started on antibiotics immediately, and just transition into the inpatient setting very smoothly.
So you have a patient with new diagnosis of AML. Let's say you have laboratory markers that come back that tell you that it has some myelodysplasia related changes, and you guys decide that CPX 351 is going to be the drug that you want to use. What are the different factors about a patient that you'll identify to decide if they can receive it inpatient or outpatient? Do you guys have like a criteria that they have to meet, or is it really going to be different for every patient?
No, we definitely have to have criteria. Even though we can do it as outpatients, there still is induction chemotherapy for acute leukemia. Patients can still get quite sick. So firstly, if a patient is so sick that they need to be admitted for the leukemia, they came in with some sort of infectious complication, hyperleukocytosis, that's probably not a candidate to discharge and then give outpatient chemotherapy to. But for the patients that are more stable, the patients that maybe are diagnosed as an outpatient or referred to us referred to our center in the clinic. So we take into account a couple of factors. We want to make sure their performance status is adequate. We usually use ECOG performance status of maybe 0, 1, and 2, being okay for outpatient treatment. We have to make sure they don't have significant cardiopulmonary disease, comorbidities, because those patients are more prone to getting severe infections and life-threatening complications. So they may not be the patients to monitor as an outpatient. The patients also can't have an active infection that needs intravenous antibiotics on a daily basis. And that's very important because there are a lot of patients with AML that do have that. And the other really important factor that I mentioned before, which is trying to figure out the patient's fitness for treatment. The patient may not have comorbidities. He might be very fit. It might seem like a perfect candidate, but if he doesn't live close to the hospital, have good transportation, have good support at home, and we cannot safely provide outpatient treatment for them. So those are most of the factors that we take into account.
Have you seen a big impact on your census or your hospital days now that you're off, you have kind of the IPOP set up?
Definitely. We use this IPOP setting for a lot of different types of treatments, not only for CPX 351. And with this type of treatment, we have been able to decrease the hospitalization of some patients. There are a lot of patients that we have admitted on our teams, but with this, we have been able to decrease that. And the patients in a typical patient being induced with either 7+3 or CPX 351 in an inpatient setting, most of these patients are hospitalized for 4 to 6 weeks, especially with CPX 351, because the recovery of cytopenia is a little bit more prolonged, closer to 5-6 weeks. So in a typical type of inpatient treatment, that's 6 weeks in the hospital. By using our IPOP setting for administration, we don't cut that down to 0 because, like I said, all patients eventually will get admitted. But we have done a pilot study and review in our center, and we saw that there's about a 50% reduction in the inpatient hospitalization days. We were able to reduce from about 35 days down to 19 days. So these patients will get treatment as an outpatient. Eventually, they'll get admitted. And sometimes we then, even once they stabilize, we'll actually discharge them again until their recovery. And decreasing the hospitalization by 50% is great for the patient and for the providers as well.
Yeah, I agree. And I can say just from my experience, with stem cell transplant as an outpatient as well, that's mainly the area that I've seen. The amount of, I think, patient quality of life really improves when they can kind of have some sense of a normal life, as well as I feel like they also are very engaged in their healthcare when they're, kind of taking care of themselves and not just in a setting in the hospital. So that's great. Amanda, can you talk a little bit more about, as the pharmacist working now, inpatient, it's kind of easy in the sense that you have rounds every day, everybody's face to face, your patients are in their room with their nurses, you can monitor them and know all their meds that they've gotten, when have they gotten them. Moving into an outpatient setting with your IPOP program, can you just kind of talk about your involvement and kind of any challenges or new workflows that you've had to come up with from a pharmacy perspective?
Yeah, it's definitely a little bit more challenging, but I think our pharmacy team has really risen to the occasion. So what we noticed was that in terms of education, it seems like patients need more and more and more, and they just need constant reinforcement of different concepts. And I think there's a lot coming at you as a patient. And so having daily touch points with a pharmacist who's reinforcing things like side effects, drug interactions, making sure that their diet is adequate is really helpful for patients. Also, as we're following the patient throughout kind of the continuum of care, different things come up. Families start to get involved, families start to give advice about certain herbal products to take or not to take, and this is really where a pharmacist input can be very helpful. So what we try to do is every time that the patient comes to the IPOP area, the pharmacist will stop by, check in, do a quick assessment, and answer any questions. In addition to certain set education sessions at the beginning of induction treatment and towards the end as the patient is being transitioned to consolidation. Now for oral chemotherapy, that's a whole other ballgame because these patients, we may not see them for weeks and weeks. They're continuing on their therapy, and we don't have that tight control that we're used to on the inpatient setting. So what we've tried to do with that, and especially in our area, since we do have a large population of patients for whom English is not their primary language, and they may have a limited English proficiency. Again, we've added in additional educational sessions with qualified medical interpreters or with staff who is bilingually certified in medical terminology. And we've added additional educational sessions to really be able to support those patients.
What do you think the experience of the opportunity of your IPOP program has been for patient outcomes or quality of life?
So for us, most of this is anecdotal, but I've heard patients say that they're just so happy to be able to sleep in their own bed, to go home to their own house on their own couch. I mean, life is not super exciting for them either way. They're not going out to participate in large concerts or events, but just being able to give patients a little piece of what you mentioned, that normalcy back, has anecdotally really helped with their morale. So I remember at first, when I first started out treating inpatient hematology, and I remember counseling a patient, and you know, the first bomb that's dropped on them is you have cancer, and then the second one is you're not leaving this hospital for at least a month, and that's a lot to process for patients. So being able to have other options, I think, is amazing.
And part of our study that we did was, of course, to also monitor, to evaluate for safety outcomes. Is it possible that by giving outpatient administration, maybe there can develop more toxicities, or the toxicities could be worse, infections could be worse. But in our study, and anecdotally, we have not found that. Safety outcomes seem to be similar, whether the patients are induced in the inpatient or outpatient setting.
Right.
Great. And Yehuda, I had a question for you. So who is the physician that's seeing the patients in the outpatient clinic? Is it the same one that's seeing the inpatient, or are they the different attendings?
So when the patients are getting treatment in the IPOP setting, so there's actually involvement by both the clinic physician as well as the inpatient physician, because if there's an urgent issue, this IPOP clinic is in the inpatient, it's right next to the inpatient unit. And some of these patients might need to get admitted. So we have a lot of communication between both the clinic physician, the inpatient physician, and all our other staff.
And Amanda, is that a similar situation with the pharmacist? Is there one in the clinic and one inpatient as well?
So there is a specific IPOP pharmacist. Our clinic is actually located right across the street, so it's not feasible as easily for the pharmacist to run back and forth. So we do have a dedicated IPOP pharmacist, and then the inpatient team literally is right next door. So that communication works quite seamlessly.
Great. Well, thanks. This has been a very rich and informative discussion so far. However, I do have some other questions that have been coming in that I wanted to see if you guys could tackle for me real quick. We were talking about, mainly we've discussed so far induction treatment and the possibility of doing that inpatient or outpatient. I was wondering, Yehuda, could you just touch on kind of what are your practices with consolidation regimens, and whether those are inpatient or outpatient?
Of course. So when it comes to consolidation therapy, these patients typically are healthier when they're getting consolidation than they were first getting induced, because when they're getting induction therapy, they're just diagnosed with leukemia, blood counts really abnormal, potentially lots of infections. When it comes to consolidation, these patients are in remission already, thank God. And so blood counts are back to normal. So just like patients usually tolerate standard consolidation therapy with high-dose cytarabine better than they do induction therapy. So the consolidation with CPX-351 is usually also tolerated better, with shorter duration of cytopenias, less infections. It's the amount of drug and number of days is lower in consolidation than it is induction. So for the patients that are able to do it in the IPOP setting for induction, they almost always are able to receive it and get the outpatient care in the IPOP setting. And even for patients who might have been induced in the inpatient setting, we will then try to continue to proceed with consolidation in the IPOP setting.
Great. Amanda, this one's for you. How often does your P&T committee meet to review your formulary?
We have a meeting once a month to review formulary, and for pathways, We have at least one pathway set revision per year, but as things are moving so fast in malignant hematology, we do make changes as new drugs are coming to market.
And for the pathway review, is that going to be the P&T committee again, or are there any different players based on whether you're just doing formulary review versus your treatment pathway review?
So we usually start off with smaller subgroups in terms of like working groups. So for pathway revisions as well as formulary additions, we'll start off in a smaller setting, maybe a team of 2 or 3 people before we open it up to a larger committee setting.
Okay, gotcha. And then you said that then initially after your HEMONC P&T will decide, and then it moves up to a larger, maybe institutional P&T that then will have the final decision?
Yeah, final decision in terms of letting the rest of the system know. We're a 5 hospital system. So we do go through the procedure of letting the other hospitals know what we're adding to formulary, just so that they're aware.
Oh, okay, great. I know you talked a little bit about in the outpatient setting your IPOP or the clinic, I guess. They could be kind of both with pharmacists in both. Do you guys do any type of follow-up outside of seeing patients when they come in for clinic visits, if they are on oral chemotherapy or some of these targeted agents?
Yeah, so regardless of whether or not we fill the medication within our own specialty pharmacy, there are pharmacists who are following the patients throughout the continuum of care and throughout their treatment. So there will be an initial education, which is either done in person or over the phone before the patient takes their first dose. Generally, there's a follow-up call 1 to 2 weeks after initiation to make sure that there's a good assessment of maybe some early side effects, toxicities, anything that has come up that the patient maybe forgot to ask during the initial educational session. And from there on, there's appointments that are made every 2 to 3 months, depending on the patient, where a pharmacist will follow up with a phone call, do an assessment, and answer any questions and assess for toxicities.
And I find that these assessments that the do are so helpful. I often get notifications from the pharmacist that the patient about this evaluation and about whatever toxicities, safety, whatever concerns come up, and many of these are taken care of without the need for without the need for an actual clinic visit. So this collaborative team is really important.
Great, thank you. I think that's all the questions that I had. Thank you again, and to our audience, we hope you found this Pharmacy Times Practice Pearls webinar to be a useful and informative discussion. Appreciate it.